Assalamu alaikum. My name is Falak Sarah. My roll number is EP1770035. Group number is 2, and the topic of my presentation is traumatic skin and soft tissue infections. There are two subtopics that I'm going to discuss here. Number one is erysipelas, and the other topic is animal bite wounds. Okay, so here I'm going to give you a brief introduction to erysipelas. That what is erysipelas? Erysipelas is basically a superficial skin infection which is caused by streptococci, predominantly of group A, but other groups may also be involved like group C or G, and in children's, streptococci group B is involved. Erysipelas is diagnosed based on the characteristic of skin lesion and concurrent systemic symptoms. The systemic symptoms that are used in the diagnosis of erysipelas include high fever, chills, frequent history of rigors, and general malaise. So, as its diagnosis based on the type of the skin lesion, we should know what is a lesion. The lesion is a continuous indurated edematous area. Edematous means there is the presence of edema, which means accumulation of fluid. In the early stages, the lesion appears to be bright red, but it may turn brown with time as it ages or grows. The lesion spread peripherally with no trace of unaffected tissue. Okay, so treat this erysipelas, we are going to give an empiric antibiotic therapy. And the antibiotics that are used here must be active against group A streptococci. The antibiotics that we use can be first we'll start with oral penicillin V with a dose of 250 milligram to 300 milligram Q6R, or we can also give parenteral penicillin G 1 million unit IV Q6R, and this should reduce the systemic symptoms of erysipelas within 24 to 48 hours. If the patient is sensitive or resistant to penicillin, we can also give clindamycin or oral quinolones like moxifloxacin. This antibiotic therapy should be continued for 10 days even if signs and symptoms resolve quickly to avoid relapse. If this relapse occurs, this could lead to chronic infection or scarring, which is absolutely a complication, and we should avoid this complication by giving the therapy for 10 days at least. So the next subtopic that I'm going to discuss here is animal bite wounds. Any wound caused by an animal that results in a skin being cut or punctured should be examined to ensure no underlying tissue damage has occurred. The wound should be washed with clean water as soon as possible after the bite. Irrigation of the wound, including the puncture site, should be extensive to reduce the risk of infection. So, the first approach, as you can see, the telling is to wash the wound and to clean it to avoid any kind of infection, any type of infection. The organisms that are involved in causing the infection are basically the most common pathogen dog bites are beta hemolytic streptococci, Streptococcus aureus, Pasteurella multocida, and anaerobic bacteria is also involved. Although P. multocida is considered the primary pathogen of dog bites, other antibiotics should be used for other common pathogens as well. Basically, you should not just treat the primary pathogen that is involved, you should focus on other common pathogens as well. So I'm going to further explain this topic by discussing this case study that I've given here. A 14-year-old boy presents to the ED 3 hours after being bitten on the leg by a neighbor's dog. He has a laceration. What is laceration? Laceration is basically a deep skin cut, 14 centimeter long on his medial calf. 4 distinct puncture marks, suggestive of teeth marks, also are present at the calf. There is no suggestion of bone injury. PJ was healthy before the attack and has chronic illness. Should PJ receive any treatment other than suturing of his laceration? So first, what we have to do is to evaluate the dog bite. The patient that we have discussed in the case study should be evaluated. Patient wound should be evaluated for deep tissue injury, devascularization of any tissue, and bone injury. Loose suturing or closure with adhesive strips is appropriate for laceration following irrigation. So first you have to clean the place, and then you can basically close the lacerated part. The patient that is discussed should be instructed to keep his leg elevated and immobilized until signs of an infection have resolved. The patient should receive a course of antibiotics if the wound involves the hand or is near joints. If it involves deep punctures or is difficult to irrigate, if the patient is immunocompromised, or if the patient is not well perfused. Antibiotics are not required for dog bites in which no deep tissue injury is present and wound can be well irrigated, particularly if the wound is on the lower extremities in healthy adults. You should also contact the local health board to determine the recent rabies risk in the area. If the patient has not received a tetanus toxoid booster within the past 5 years, a booster should be. If the patient has never been immunized for tetanus, tetanus immune globulin should be administered in addition to toxoid. Okay, so what is empiric antibiotic therapy that should be given here? If you remember, there was a part which says that if the patient requires any further treatment for infection or not, or just requires suturing of laceration. So the answer is here. Because patient has several punctures that are difficult to irrigate, he is a candidate for antibiotic therapy. But if there's no deep cut or not deep punctures, we do not have to give antibiotic therapy if there's a dog bite. So the answer is here that the patient should be given antibiotic therapy because he has very deep cuts and deep punctures, several punctures, which are very difficult to irrigate. So the empiric antibiotic therapy that we are going to give here is monotherapy with amoxicillin and clavulanate, 500 milligram and clavulanate 875 milligram orally, Q12R is recommended. If the patient is allergic to penicillin, tetracycline or doxycycline provides adequate coverage. We prefer doxycycline over tetracycline because it is more convenient to administer. 2 doses of doxycycline are given per day, but tetracycline is required to be given 4 times a day. It can be used in patient with decreased renal function, and it can be taken doxycycline can be taken with food. And the only disadvantage that we can focus here or we can see here is that doxycycline is a little more expensive than tetracycline. If the penicillin allergic patient cannot take doxycycline, a fluoroquinolone such as moxifloxacin 400 milligram per oral daily can be used. In all the cases discussed above, patients should be instructed to watch for a positive response. Antibiotic treatment should not extend beyond 5 days unless signs of infection remain. Appropriate therapy for this patient would be penicillin V and penicillinase resistant penicillin, example dicloxacillin or cloxacillin orally. If the patient has not responded to the oral therapy, parenteral second generation cephalosporins such as cefoxitin 1 gram IV Q6R and ceftriaxone 1 gram IV Q8R has activity against P. multocida, streptococci and cephaloccocci and anaerobes. The value of parenteral administration of clindamycin or erythromycin is very limited by poor activity against P. multocida. Okay, so till here we have discussed about the dog bite because the case that we have studied here is about. So now I'm gonna tell you, I'm gonna give you a brief introduction for the cat bites and what we should do if there's a cat bite. So cat bites, the role of P. multocida appears more significant because this organism can be found in the oral flora of up to 75% of cats. Although antibiotic treatment is not required for some dog bites that we have discussed earlier, that if there is no deep punctures or no deep skin damage, then the all the condition can be handled by only irrigation. But if there is deep cut or deep infection, we have to give antibiotic. So in dog bites case, we don't have it is not required to give antibiotic, but in the case of cat bites, it is suggested to give antibiotic therapy. Because P. multocida often is resistant to penicillinase resistant penicillin and first generation cephalosporins, use of these agents in cat bites should be avoided. So we should not give penicillinase resistant penicillin and first generation cephalosporin in the cat bite, but we can give that in dog bite. Therapies discussed above for dog bites would be appropriate for treating cat bites as well. So this is all about my presentation. Um, Thank you.